You have 18 months. That is the absolute maximum time you have before a denervated muscle atrophies into useless, irreversible fat.
Yeah, the clock starts at the literal second the trauma shears cut the nerve.
Exactly. I mean, in peripheral nerve injury, you are not just plating a static bone, or covering a defect with soft tissue. You are trying to repair the live communication grid of the human body.
Right, and knowing that a millimeter of scar tissue in the wrong place, that can mean the difference between a fully functional hand and a permanent claw deformity.
It's incredibly high stakes. So for this deep dive, we really want to decode that complex wiring of the upper extremity. We need to look at how these peripheral nerves respond to trauma and where they predictably get trapped.
Because before you step into the OR to fix that grid, you have to understand the architecture you are dealing with under the microscope.
Right.
The basic wire is the axon, and that single axon is wrapped in its own individual insulation, which we call the endoneurium.
Okay, so you take groups of those insulated wires and bundle them together into fascicles, right?
Yeah, exactly. And the fascicle is the critical structure for us surgically.
Because when you are looking through the scope, that is the smallest anatomical unit you can actually dissect and repair.
You got it. And that fascicle is bound tightly by a layer called the perineurium. Then you take a collection of those fascicles, group them together, and wrap the entire cable in a thick outer layer.
The epineurium.
Yes, the epineurium. And that outer layer is what allows the nerve to physically glide past joints, tendons, and muscles without tethering during normal movement.
It is a beautifully redundant system, well, right up until it takes a traumatic hit.
True.
When we look at how these nerves fail, despite the endless ways a patient can injure an arm, a crush, a sharp laceration, a high-energy traction injury, the nerve itself really only have two basic pathophysiologic responses.
Right. The first response being focal demyelination. The insulation gets damaged, usually from a mild compressive force, but the internal wire, the axon itself, is completely spared.
So the local Schwann cells can just step in and repair that myelin sheath over a few weeks.
Exactly. But the second response is where things get surgical, and that's axonal degeneration. The physical wire breaks.
And when that axon snaps, everything distal to the injury site undergoes Wallerian degeneration.
Yeah, the distal axon doesn't just sit there, it executes a programmed death.
Right, the macrophages move in, they clear out the myelin debris, and they empty the endoneurial tubes to make physical room for new nerve growth from the proximal stump.
Which is why Seddon's classification maps this clinical reality so perfectly.
I always break down Seddon's system for the juniors using an electrical cord analogy.
Oh, yeah, I like that one.
Right. So Neurapraxia is like twisting the cord so tightly that the signal drops. The copper wire inside is perfectly fine, the rubber casing is fine, but the twist creates a physiological conduction block.
Usually from that focal demyelination we just talked about.
Exactly. So you relieve the pressure, untwist the cord, and the nerve recovers spontaneously in 2 to 3 months.
But then moving a step up the severity ladder, you have axonotmesis. That's when you pull the cord hard enough to snap the copper wire inside, but the outer rubber casing remains completely intact.
Right. So the axon is cut, meaning you get Wallerian degeneration, but those microscopic endoneurial tubes are still physically continuous.
Which is huge because those intact tubes act as physical guide rails. Once the macrophages clear the distal debris, the axon regrows down those exact same biological tunnels.
At a highly predictable rate, too, roughly 1 millimeter per day.
Yeah, so the prognosis for spontaneous recovery is excellent because the wiring has a map to follow.
But then you hit neurotmesis, which is the worst-case scenario.
Mm-hmm.
In the cord analogy, that is taking a pair of heavy trauma shears and cutting the entire cord in half.
Complete transaction. The axons are cut, the tubes are cut, the outer epineurium is breached, everything is gone.
So without those guide rails, the regenerating axons just sprout from the proximal stump and hit a chaotic wall of scar tissue.
And tangle into a painful neuroma, yeah. The surgeon has to physically coapt those ends, or the target muscle will never see another electrical signal.
And Sunderland took Seddon's concepts and expanded them into 5 degrees of injury. The one that always creates an absolute nightmare in the OR is the 4th-degree injury.
Oh, the 4th-degree injury is the ultimate surgical trap.
Because you have total loss of the axons, the inner endoneurial tubes, the perineurium. I mean, everything inside the cable is obliterated by trauma.
But the outer epineurium remains visually intact.
Right. So you open the arm, dissect down to the zone of injury, and the nerve looks like it is still in one continuous piece. The epineurium is bruised, sure, but it hasn't snapped.
But inside that intact sheath, it is a dense neuroma in continuity. The regenerating axons are completely blocked by internal fibrosis. Spontaneous recovery is physically impossible.
You are staring at a nerve that hasn't technically been transected, but you still have to cut out that scarred segment and graft it, or the patient gets nothing back.
Which brings up the most terrifying variable in nerve surgery,
Right.
right? Timing.
Yeah, moving from textbook physiology to the trauma bay, the mechanism of injury completely dictates your timeline.
Exactly. If a patient comes into the ED with a penetrating trauma, say, a sharp glass laceration to the volar forearm, and a profound neurologic deficit, you assume neurotmesis.
You explore early, ideally washing it out and repairing it within 72 hours while the nerve ends are pristine.
But a severe crush or a high-energy avulsion demands the exact opposite approach.
Wait, really, why is that?
Because if you explore a crush injury on day one, you will fail. You simply cannot define the true zone of injury under the microscope yet.
Ah, right. The nerve ends look viable on day one, but they will undergo progressive necrosis and die back over the next 2 weeks.
Exactly. You have to wait 2 to 3 weeks, let the tissue declare itself, and then go in. You'll almost always need nerve grafts or synthetic conduits to bridge that resulting gap.
And if it's a severe traction injury to the brachial plexus, you might even see a Horner syndrome.
Yeah, that drooping eyelid, that ptosis that tells you the root is avulsed straight off the spinal cord. It changes your entire reconstructive algorithm.
So for closed injuries where the nerve remains in continuity, we observe. But observing does not mean blindly waiting. We rely heavily on EMGs in nerve conduction studies.
And the most common pitfall I see from the emergency department is ordering an EMG on day one of a closed injury.
Oh, it happens all the time. But a day one EMG provides zero actionable data for an acute nerve injury.
Right, because you are looking for electrical evidence of axonal damage, specifically denervation potentials in the target muscle.
And those muscle fibers won't start fibrillating until they completely lose their chemical connection to the nerve.
Which requires Wallerian degeneration to fully run its course. It takes a minimum of 3 to 4 weeks for those electrical signs of muscle denervation to actually show up on the monitor.
This is the exact clinical dilemma that drives me crazy in practice. Say I have a patient with a closed humeral shaft fracture and a dense radial nerve palsy.
A classic scenario.
I cannot physically see the nerve. I don't know if it is a simple axonotmesis that will recover on its own, or a Sunderland fourth-degree neuroma in continuity that needs to be cut out.
Right.
So how long can I safely wait for clinical or electrical signs of recovery before I permanently lost the window to save those target muscles?
3 to 6 months. That is your absolute boundary. You cannot passively observe beyond that because of the ticking clock of muscle atrophy.
Because a denervated muscle loses roughly 1% of its physical mass every single week.
1% a week is a massive physiological toll. By the time you hit that 3 to 6 month mark without any clinical motor return or electrical recovery on the EMG, you are forced to explore.
And if you wait past the 12 to 18-month threshold,
The motor end plate, the actual junction where the nerve talks to the muscle, degrades completely. The muscle undergoes irreversible fatty fibrosis.
so once that happens, doing a perfect microscopic nerve repair is totally useless. The target is dead.
Completely dead. You are abandoning nerve surgery and looking strictly at salvage tendon transfers just to restore basic biomechanics.
And that rigid 18-month deadline applies to everything we do. So, shifting our focus from acute trauma to chronic compression, let's look at the most common offender in the upper extremity.
The median nerve, specifically as it runs through the carpal tunnel.
The anatomy there creates a perfect storm for compressive ischemia. It's a rigid, unyielding box.
Yeah, the floor and walls are formed by the carpal bones, and the roof is the thick transverse carpal ligament.
And the median nerve sits in a superficial and radial position right beneath that ligament, sharing the tight space with 9 flexor tendons.
So when the synovium around those tendons swells, the pressure in that rigid box spikes.
Which gives us the hallmark symptom of carpal tunnel syndrome, night pain. Patients wake up at 2 a.m. vigorously shaking their hands to restore blood flow.
And when evaluating them in the clinic, catching that sensory drop early is critical. We often reach for 2-point discrimination, but Semmes-Weinstein monofilaments are vastly superior.
Because 2-point discrimination tests innervation density, which stays intact for a long time, right?
Exactly. Monofilaments test threshold pressure, which is the very first thing to fail when a nerve becomes ischemic.
Now, managing these patients non-operatively with corticosteroid injections requires some aggressive expectation management.
Definitely. A steroid injection into the carpal canal will give transient relief to about 80% of patients by knocking down the synovial inflammation.
But if you track those same patients out to 1 year, Only 20% remain completely symptom-free.
Right. We are usually just buying time before a surgical release. But before we take a patient to the OR to divide that transverse carpal ligament, we have to definitively prove the median nerve isn't being crushed further up the arm.
Pronator syndrome. A proximal compression around the elbow that will absolutely humiliate you if you miss it.
Well, both carpal tunnel and pronator syndrome cause profound numbness in the thumb, index, and middle fingers. But the clinical presentation is quite different.
Pronator syndrome is mechanically driven by forearm rotation. The pain triggers with heavy, repetitive activity, not at night.
And the physical exam is where you make your money here. You have to check light touch sensation directly over the fleshy thenar eminence at the base of the thumb.
This is such a cool anatomical trick. The palmar cutaneous branch of the median nerve provides sensation to that specific patch of palm.
And that tiny branch takes off roughly 5 centimeters proximal to the wrist crease.
Meaning it travels completely over the top of the transverse carpal ligament, not inside the carpal tunnel.
That piece of anatomical trivia dictates your entire surgical incision. If a patient has numbness in their radial digits, but the skin over their thenar eminence feels perfectly normal,
The compression is trapped locally at the wrist. The palmar cutaneous branch escaped the crush.
Exactly. But if the thenar eminence is profoundly numb as well, the trap is proximal to the wrist higher up at the elbow. The entire median nerve cable is being choked before that branch even takes off.
Now, the median nerve throws one more curveball just distal to the elbow. The anterior interosseous nerve, or AIN.
AIN syndrome is a diagnostic nightmare because it is a purely motor presentation.
Right. There is zero numbness, zero tingling, zero pain.
The AIN branches off and dives deep to supply 3 specific muscles: the flexor pollicis longus, the deep flexors to the index and middle fingers, and the pronator quadratus.
The clinical test for this is so simple, though. You ask the patient to make an OK sign with their thumb and index finger.
And they physically cannot do it.
Because the flexor pollicis longus is dead, the interphalangeal joint of the thumb collapses into extension. They end up making a flat, awkward pinch.
We typically manage AIN syndrome with 3 to 6 months of observation, since a significant percentage resolves spontaneously without surgical decompression.
Okay, let's contrast the median nerve's static bony box with the absolute mechanical nightmare that is the ulnar nerve.
Oh, the ulnar nerve faces a unique challenge. It runs completely behind the axis of rotation at the elbow, setting the stage for cubital tunnel syndrome.
The biomechanics of the cubital tunnel are just hostile to nerve health. Because the nerve sits behind the medial epicondyle, every single time you flex your elbow to bring your hand to your mouth, the ulnar nerve is stretched by 5 millimeters.
5 millimeters of longitudinal traction on a fixed cable.
And at the exact same time, the retinaculum forming the roof of the cubital tunnel flattens out, dropping the physical volume of the space by over 50%.
So the nerve is being stretched and crushed simultaneously.
And there are 5 distinct anatomical checkpoints where it gets tethered across that elbow space, right?
Yeah, proximally you have the arcade of Struthers, a fascial band that tightens during extension.
Then moving distally, it can tether at the medial intermuscular septum.
Right. Then you have direct bony compression right behind the medial epicondyle.
The 4th site is Osborne's ligament, the fascial band connecting the 2 heads of the flexor carpi ulnaris,
which acts like a tight band during elbow flexion. And finally, it dives deep through the flexor pronator aponeurosis.
When the ulnar nerve undergoes chronic compressive ischemia at the elbow, the intrinsic muscles of the hand slowly starve.
And the resulting motor signs are visceral. You see Wartenberg's sign, where the pinky drifts away into abducted isolation.
Because the palmar interosseous muscles are too weak to pull it back in.
But the most striking visual is Froment's sign.
I love this test. You hand the patient a thin piece of paper and ask them to pinch it between their thumb and index finger.
And the adductor pollicis, which is ulnar innervated, is dead. They cannot pinch the paper flat.
So to compensate, their brain recruits the flexor pollicis longus, which is median innervated.
You literally watch their thumb IP joint aggressively hyperflex just to maintain a group on the paper.
You also see Jean's sign, where the thumb MCP joint hyperextends during that exact same pinch maneuver.
Yeah.
So looking at this mechanical disaster, the tension, the dynamic volume drop, the 5 compression sites, why isn't the gold standard to just surgically transpose every single ulnar nerve?
I mean, why not completely dissect it out of the cubital tunnel and move it to the front of the elbow where it will never get stretched again?
Right.
Well, that question has fueled decades of intense debate in orthopedic and plastic surgery. Anterior transposition makes perfect mechanical sense.
But surgically, the morbidity is high.
Exactly. To move the nerve, you have to dissect it extensively over a long segment, aggressively stripping its extrinsic blood supply. You risk devascularizing the very nerve you are trying to save.
Plus, if you don't perfectly release the medial intermuscular septum, you just create a new iatrogenic kink in the nerve at its new location.
Which is why recent massive meta-analyses heavily favor simple in situ decompression for primary cases.
You just open the roof of the tunnel, divide Osborne's ligament, and leave the nerve in its native, well-vascularized bed.
The clinical outcomes are identical to transposition, with a fraction of the surgical complication rate. Assuming, of course, the nerve isn't chronically subluxating back and forth over the medial epicondyle.
Now, just like the median nerve, the ulnar nerve faces a secondary distal trap at the wrist, Guyon's canal, or ulnar tunnel syndrome.
Bordered by the pisiform bone on one side and the hook of the hamate on the other.
But ulnar compression at the wrist is significantly less common than at the elbow.
Yeah, when a patient presents with it, your immediate clinical suspicion should jump to a space-occupying lesion.
Like ganglion cysts arising from the carpal joints, they are massive culprits.
We also see it in occupational trauma, specifically hypothenar hammer syndrome. Mechanics or carpenters who use the butt of their palm as a hammer physically crush the ulnar nerve.
And they can literally thrombose the adjacent ulnar artery.
Surgically, Guyon's canal is mapped into 3 distinct zones based on how the ulnar nerve bifurcates.
Zone 1 is proximal to the split, meaning compression here causes both intrinsic motor weakness and sensory deficits in the pinky and ring fingers.
Right. Then Zone 2 isolates the deep motor branch as it dives sharply around the hook of the hamate, causing pure weakness.
And Zone 3 involves only the superficial sensory branch.
But the clinical pearl to differentiate Guyon's canal from cubital tunnel syndrome lies entirely in the dorsal sensory branch of the ulnar nerve.
Because this branch provides light touch sensation to the skin on the back of the ulnar half of the hand.
And crucially, that dorsal sensory branch takes off about 5 to 8 centimeters proximal to the wrist. It never enters Guyon's canal.
Exactly. So if the back of the patient's ulnar hand is numb, the compression has to be proximal to the wrist. It is cubital tunnel syndrome.
But if the back of the hand has perfect sensation, but the palmar side of the pinky is numb, the compression is isolated to Guyon's canal. The physical exam literally draws the surgical map.
Let's complete the major triad with the radial nerve. The radial nerve anatomy in the proximal forearm presents one of the most confounding mechanical puzzles in all of peripheral nerve surgery.
Because a single anatomical tunnel can produce 2 diametrically opposed clinical nightmares.
As the radial nerve crosses the elbow joint, it bifurcates.
Yeah, the superficial sensory branch continues straight down the forearm under the brachioradialis, but the posterior interosseous nerve, the pinin, takes a sharp dive deep into the muscle belly of the supinator, entering the radial tunnel.
We track 5 potential compression sites for the pin. Fibrous bands anterior to the radiocapitellar joint, the vascular leash of Henry, the tendinous edge of the extensor carpi radialis brevis, the distal edge of the supinator,
And the most notorious anatomical guillotine in the forearm, the arcata frosa, which is the thickened, fibrous proximal edge of the supinator muscle.
The arcata frosa is the primary compressive culprit in almost all cases. But compression at this exact same fibrous arch leads to 2 completely divergent diagnoses: radial tunnel syndrome, or RTS, and pin syndrome.
This is what drives surgeons crazy in clinic.
Right, you have 2 patients, same nerve, same tunnel, same arcata frosa, acting like a garrote. One patient is screaming in proximal forearm pain, but has perfectly normal strength. That is RTS.
And the other patient cannot lift a single finger to save their life, but feels 0 pain. That is pin-end syndrome.
Mechanically, how is that even possible?
It is one of the great lingering debates in our field. The prevailing theory comes down to fascicular topography and ischemic thresholds.
So the pain fibers in the radial nerve might sit more superficially in the cable.
Exactly, making them susceptible to intermittent dynamic compression during forearm rotation. That causes the severe pain of RTS without starving the deeper motor fascicles.
But with pin syndrome, the compression is relentless and absolute, crushing the motor fascicles entirely.
Now, RTS is incredibly easy to misdiagnose as lateral epicondylitis or tennis elbow.
The key distinction is location. Tenth elbow pain is localized directly over the bony lateral epicondyle. RTS pain is centered 3 to 4 centimeters distal to the joint, deep in the mobile wad of muscle over the radial tunnel.
Furthermore, the ELG in RTS is notoriously normal, which makes some surgeons skeptical of the diagnosis altogether.
We often rely on a diagnostic block. You inject local anesthetic directly into the radial tunnel.
Right, if the patient's chronic pain vanishes instantly, but they temporarily lose the ability to extend their fingers because you bathed the motor nerve in lidocaine, you have confirmed the diagnosis of RTS.
Pin syndrome is the sinister counterpart. It is profound motor weakness. The patient suddenly cannot extend their fingers at the MCP joints, and they cannot extend their thumb.
But the diagnostic trap with pin syndrome is evaluating wrist extension. The extensor carpi radialis longus, the ECRL, receives its innervation from the radial nerve high up before the nerve ever enters the radial tunnel.
So the ECRL is totally spared from the compression.
Yes, the patient can still powerfully extend their wrist, but because the extensor carpi ulnaris and the ECRB are paralyzed by the distal compression, the unopposed pull of the ECRL yanks the wrist into sharp radial deviation every time they try to extend it.
And when you see that sudden loss of finger extension, you always have to rule out mechanical tendon ruptures, especially in patients with severe rheumatoid arthritis.
You perform a tenodesis test.
Right, you passively flex their wrist. If their fingers automatically pull into extension due to the mechanical tension on the intact tendons, you know the plumbing is connected. The problem is purely electrical. It's the nerve.
Now, the radial nerve has one final, purely sensory trap just proximal to the wrist called Wartenberg syndrome.
The superficial radial sensory nerve has to exit the deep fascia to become subcutaneous, passing tightly between the brachyradialis and the ECRL tendons.
During forearm pronation, those two tendons scissor together and crush the nerve.
It causes burning, painful dysesthesias over the dorsoradial back of the hand.
And while it can be anatomical, it is almost always driven by external mechanical compression.
Handcuffs are the classic mechanism, literally crushing the superficial nerve against the radius. A tight wristwatch or restrictive wristbands will do the exact same thing.
Usually just removing the external mechanical compression allows the nerve to recover without surgical release.
All of this anatomy really brings us back to the core surgical reality. We treat peripheral nerves like electrical wires, but they are not inert copper.
No, they are fluid-filled, highly vascularized, living structures. They demand continuous, uninterrupted blood supply. They absolutely demand the physical ability to glide.
The moment a nerve loses its glide due to trauma or a tight fascial band, it tethers.
The moment it tethers, normal joint movement aggressively stretches it.
And the moment it stretches beyond its physiological limit, the internal blood vessels collapse, and the nerve undergoes compressive ischemia.
That ischemic cascade is the common pathophysiological pathway for every single entrapment we discussed, from the carpal tunnel to the arcade of Fossa.
So the surgeon's primary mandate is to relieve that mechanical pressure, whether cutting an intact anatomical ligament or meticulously excising post-traumatic scar tissue under the microscope, before the motor end plates permanently die at that 12 to 18-month mark.
The timeline dictates your surgical urgency, and your physical exam, knowing exactly which branch innervates the thenar eminence or the dorsal hand, separates the elbow from the wrist.
Identifying the precise point of failure makes the difference between restoring a patient's limb function and leaving them with an irreversible clawed hand. You are operating on the human communication grid. Knowing exactly how it is wired and exactly where it shorts out is everything.
Because the anatomy forgives nothing in the operating room.
Very true. Well, that wraps up our deep dive. We will see you in the OR for the next case. Take care.